looks like I have to bring up the rear, as they say. That's good though. But this is one of those type of scenarios that will definitely keep you awake if you ever have to be involved with one. Mass casualty scenarios is a nightmare for anybody, at any scenario, any place, no matter what it is. And we've got plenty of examples in media we've covered. But my basic approach is just to give you the pearls and watch out for certain things that can go wrong. So the basics of mass casualty is it's a mess. It's an absolute mess. It is chaos. That's by definition. But your resources get overwhelmed. You have too many patients. You have to figure out a system to triage, sort the wounded, and get them to a definitive care. So the types of events: terrorist bombings, airplane crashes, railway incidences, weather-related in our country right now, going through horrific tornadoes. It just totally denudes your whole system as far as resources and people to try to help with that. So with terrorist bombs, I like to spend a little bit on this because I'm a blessed expert, but they give you the largest psychological effect on your population. Everybody panics. If there's a tornado, sure, or if you're a railway accident, sure. But when a bomb goes off, like in Boston, everybody gets panicked and you get overwhelmed by the non-sick, the worried well, so to speak. So patients that are 75% of those victims will refer themselves to your medical centers. So, and they'll come by private transportation. There is a huge problem. Now you have two sources of triage, on site and also in your emergency department in your hospital. Patients may also need decontamination from these bombs. Think about that, dirty bombs, chemical bombs. These are things you cannot think of at the time. You have to think about them ahead of time. That's the focus of this speaking engagement today. Injury patterns related to explosive events depend on the environmental setting and the types of explosives, like in Boston with the pressure cooker bombs and so forth. But blast injuries should be suspected no matter how far away they are. So the old dogma we're trying to ruin is that, well, if you're close to it, you're going to get injured more. Not so, with overpressure injuries and shrapnel and so forth. So, mass casualties, large numbers of patients will not be critically injured. They'll be minor, and this is our job as professionals to figure out, yes, you can wait, and no, we need to take this patient right away. 20% will have critical injuries. Your medical resources become overwhelmed, but you have to understand that there's going to be hundreds of patients who do not need immediate medical attention. So, the pearls in planning and drills. This is the biggest take-home point today for the crowd. You have to come up with a mass casualty incident response plan for your municipality or your hospital, and you have to coordinate that with your GARDA and with all the other public, the firemen and so forth. And that is very, very important, because if you do it in a vacuum, well, we're this hospital and this is what we're doing, and we're this first responder, we're doing this. None of that is going to matter when the bomb goes off, so to speak. You have to drill. You have to do it regularly, at least once a year. You got to pull that thing off and go through it step by step. And if you don't do that, it's going to be, instead of controlled chaos, it'll be total chaos. So have your equipment and your supplies out as well. It doesn't do you any good to have tentage and kit that you haven't seen before, or it's not what you normally use. Again, we're trying to limit the chaos effect. So the pearls is, number one is communication. This is a standard in the military, and it's a standard EMS. And in a mass casualty, it is the only way you're going to be able to deconflict what's going on. If you don't have it, it's total chaos. If you have it, you have controlled chaos. You have to assign radio frequencies so that everybody who's important is talking on the level, so that information flows up so that people can coordinate on the other end. So everybody knows about effective triage. At least I hope so. You want to sort those wounded out. You have to just delineate who's who. Your 1.5%ers, the red ones, those need immediate care right now. The ones that are not breathing or having problems with the oxygenation. Yellow, more complex, not immediate life threats. Greens, walking wounded. The black or blue, depending on what system you look at, those are the dead or the expected ones. So, on-scene triage. This is very important. And we've seen great strides in mass casualty management by having effective on-scene triage. It'd be great if you had a senior medic, senior nurse, or optimally an emergency physician out there using an ultrasound doing triage. Another take-home point, everybody needs to take this into mind. Triage is a dynamic process, not static. You're always going back and reevaluating, because they can change color codes and need to be evacuated sooner if they start to decompensate on you. A yellow doesn't mean it's going to be a yellow forever. Don't make that mistake. So wear identification for your personnel. I do advocate ultrasound on scene and a qualified provider. It is invaluable. We used it in the war, and it was unbelievable at helping us doing a fast ultrasound to look for bleeding to get them out sooner. Emergency department in the hospital, triage, re-evaluating them, going out and saying, this is a yellow, now it's a red, so forth, and helping out and guiding your patients. Delineate your ground evacuation routes and have your guard or personnel help you as well. This is where that communication piece is critical. Because without them doing their job and protecting you to get the patients in, it doesn't do any good. It just becomes a tangled mess. So, public relations. This is important too because you're trying to keep the walking worried well away from the hospital. You have to get these informations out there. Safety, correctness, don't give out bad information, get the families reunited as best you can, and promote hope. And then over triage is another bad thing. If you can't make a decision, or if you over triage everybody, they're all yellows. That's not going to do you any good. You're back to where you are. The lack of coordination. You've got to have that coordination, okay? You have to, over triage can also lead to more mortality. There's one study that showed that. So lack of drills, bad, because it doesn't do you any good either to have that big book on the shelf and not use it, and not talk about it. So it's incumbent on all of our leadership to do that. So communication, lack of having that, lack of having evacuation plans, lack of pre-stage supplies and familiarization with them, a recipe for disaster. You already have one disaster, don't make a secondary disaster by not being planned. So failure to re-triage patients, I'm going to hit that as one of my last notes because I have seen patients come in, and for my awesome first responders, my medics, and the patient's dead. That didn't do anybody good because they just didn't look at him again. So keep that in mind. Dynamic. Any questions at all?